Hello, everyone. My name is Gary Cohen. I'm one of the founders and president of Healthcare Without Harm, and I'm really pleased to have you all join us today for a conversation that I'm going to have with Don Berwick, who is one of the founders of the Institute for Healthcare Improvement and the former director of the Center for Medicaid and Medicare Services. This is the continuation of a conversation that we've been having probably for a decade about the future of healthcare and how do we incorporate what we are understanding about the conditions that people face to the best kind of healthcare delivery that we can have in this country. So I have a whole series of topics we're going to cover, and we're going to start with our current predicament, which is that we're in the middle of a COVID crisis. And in that crisis, hospitals have become the epicenter of our collective trauma. They're the ground zero in the fight against the virus. And it's where the sickest people are taken, either to be treated and to get better, or many of them to die, more than 500,000 people in America. And over the last year, we've learned about the fragility of the global supply chain for ventilators, for personal protective equipment. It's put healthcare workers on the front lines of having to risk their own lives to save others. It's also exposed the glaring contradictions in our system. So within the first few months of the pandemic, over 1 million healthcare workers were laid off, just at the moment where we could have been doing contact testing and people needing more healthcare workers. And the pandemic, as many of us have realized, has also laid bare the incredible health inequities that exist in our country, where Native people are dying at three times the rate of white people. Black people are dying at twice the rate of white people. There's a lot of other things that have surfaced in this pandemic that are so important for us to learn. For you, Don, what are some of the most important takeaways from the pandemic?
First, Gary, let me just thank you for the chance to join you and express my admiration for you and your leadership for decades now, and for Healthcare Without Harm. You've changed the world, and I think actually we have a lot to learn from your constancy and your wisdom about how to capitalize on this tragedy and make it into something lessons learned. I have so many takeaways. I guess just to start with something positive, there's been a very thrilling response from the healthcare world to the COVID pandemic overall. That includes speed of learning, the pace at which physicians and nurses and leaders in healthcare around the world are sharing knowledge and information and growing their skills. And we can see it in the results of COVID care. We've been rather slow sometimes to share what we know, not now. It's been breathtaking. Our journals are moving at a pace I've never seen before. Our standard setters, like the National Academy of Medicine, are able to do things in weeks that would have taken literally years. So we're learning about adaptation. The healthcare workforce has been tremendous. I just had an interview this morning with the CEO of Northwell Health, just recounting the rising of the healthcare workforce to their calling. It's really thrilling. And I have to tip my hat to the pharmaceutical industry. I mean, normally I'm critical of them in many ways, but what that industry did with the vaccine was really pulling rabbits out of a hat. It's been, saved millions of lives. So that's all good. But you're right. A lot of the lessons we've learned have been getting our hands slapped badly. I guess starting with pandemic preparedness itself, we were not prepared. And you know what? We knew it. There have been multiple reports from prestigious organizations, including several from the National Academy of Medicine, one that I co-chaired with Ken Shine just a year before COVID, showing that we were not ready. We didn't have the stores, we didn't have the habits of sharing, we didn't have the data systems, we didn't have the supply chains. And we knew it. We didn't know that it will be COVID, and next time it won't be COVID. Next time it'll be the grid goes down, or there's bioterrorism, or some other massive insult. But we've got to learn now that being prepared is wise, and how to do that. We didn't have habits of regional cooperation. Responses to the COVID emergency require high levels of exchange and cooperation of materials and knowledge and personnel and data. And those habits are not embedded in healthcare. They're not. In fact, we built a more and more siloed industry. We have the equity problem you mentioned. No surprise at all to health services researchers like me. We probably could have told you what would happen, but death rates for African Americans at 2, 3, 4 times whites, for Native Americans the same, and unfairness to incarcerated people. We have the 90 of the top 100 outbreaks by August 2020. 90 out of the top 100 outbreaks numerically were in prisons and jails. No capacity to respond. I hope we can come to a kind of reckoning here. We've had the chronic erosion of human dignity and survival and thriving due to racism and its consequences, and to othering in general. It's more vivid in the COVID pandemic. Can we please learn from this and change? I really hope that'll happen. The healthcare workforce now I think what's happened is it's a bigger idea than we knew before. The healthcare workforce is a much more capacious notion now, many more roles and disciplines, many more people when we use that term.
Mhm.
And we also know that they need support at a level we didn't understand before: psychological support to balance their lives at work and their lives at home. All of these we could take all of these and make a real different future for healthcare if we want, and I hope we will.
Well, we have a huge opportunity to do so in this current administration. One of the things that was very apparent, and it's still apparent in the COVID epidemic, is the science as a contested space. What works? What doesn't work? How does it spread? That seems to play out across party lines. It seems to play out across states. Some of the same forces that doubt the reality of the COVID epidemic, the science around it, are the same forces that actually deny that the climate crisis is real. How do we deal with that? It seems unprecedented, the level of skepticism around science as a fundamental building block for addressing our society's problems.
Absolutely, Gary. I mean, as you said, you knew that long before others did. You experienced it because climate denial and the anti-scientific view of climate has been with us for decades now, and perhaps a little less so in healthcare until this COVID experience. As you know, it's a layered problem. The immediate problem was leadership. We had, from the highest levels of our government, irresponsible levels of scientific skepticism and blindness, apparently not understanding the scientific method itself and willing to lurch at unproven and unwarranted, unsupported ways to deal with a pandemic. So we had a leadership failure. That's corrected now, I hope, and we'll see much more consistent, mature messaging in the embrace of science. The appointment of the presidential science advisor now, the elevation, Eric Lander is the science advisor now, will be at the cabinet table. I think that's a magnificent move, and it's proper. The mastery of technology and science at the highest levels of policy is now, it's in the country's interest. I think there is a maturational question here. COVID was unusual because so much about it was unknown when it arrived. We didn't understand the virus. We didn't know the treatments. We didn't have a vaccine. We didn't even understand the epidemiology and the spread. All that got worked out, to a level that is thrilling, actually, what we now know that we didn't know. But during that period of scientific development, scientists, like everybody, had uncertainty. We actually didn't know what role masks would play. We didn't know whether remdesivir, where it would work. We didn't know if hydrochloroquine would help. We've learned every one of those now, and we have the data, but that means that this public watched uncertainty evolve towards certainty, and a mature public dealt with in a respectful way will understand that, of course, that we're learning our way to truth. But an immature public, one that isn't supported that way, one that isn't supported through education and leadership, can say, well, wait a minute, I thought you said A, now you're saying B. The answer is yes, we thought A, then we used science, and now we know B. that's another opportunity. Maybe we can develop a whole new level of understanding in the public about the scientific method itself. And we do effectively.
That's a hopeful thought. I mean, I think we need to do that also around the climate crisis because we're learning as we go. There's a lot we know.
It's a double challenge. It's the messaging about that, the learning, and learning is the name. All improvement is learning. I mean, that's, you know that, and I know that, but that means you go through periods of uncertainty. But the double challenge is it has to be done with enormous respect. The public does not and should not tolerate arrogance, finger wagging, and saying, looking down on people who are asking very legitimate questions. So we have to develop as scientists, I think, forms of empathy and respect and dialogue with people who are asking questions that are not surprising.
Yeah.
We need to be in conversation. I think that's really important.
Yeah. I mean, the other thing that strikes us at Healthcare Without Harm and it's accentuated since the COVID epidemic is that not only does the health sector sit at the center of the collective trauma, but can also be in a unique position to be a partner in collective healing. And so we've learned as the science evolved is that fossil fuels is one of the leading vectors of disease in the world. Not only are millions of people dying each year from air pollution related to the combustion of fossil fuels, but billions more people are being exposed to toxic chemicals through water, through air, through consumer products, through food, to the extent that we're all carrying trace amounts of toxic chemicals in our bodies. And these are linked to cancer, immune dysfunction, learning disabilities, reproductive disorders. And those same petrochemicals are also being used as pesticides on the food we grow. And then we're trying to feed our kids healthy food and unwittingly exposing them to pesticides. So the health sector is 20% of the entire US economy just about now, and has all the contradictions of that economy built on fossil fuels, toxic chemicals, and industrial agriculture. It's through its energy, it's reliant on fossil fuels. For a lot of its products and technologies, it's bringing toxic chemicals embedded into its facilities. The food that it serves is also often with the fruits of industrial agriculture. So at least we've been involved. Healthcare Without Harm has been so focused that the mission of, in the 21st century, of healthcare, the health sector, is not just treating people individually for the diseases they have, but actually being involved in a much broader healing mission of healing the economy. And you've talked in the past about how do we move past hospitals as repair shops and moving upstream to address these social and environmental conditions that are making people sick in the first place. With this center of this economy, this fossil fuel economy, being such a powerful negative influence on people's health and the economy, how do you react to this strategy to sort of make this a strategic priority for the health sector?
I react very positively to it. You've been so disciplined and eloquent in Healthcare Without Harm since I first encountered you in your work 20 or 25 years ago. You and I have had conversations, Gary, about whether something related to sustainability or environmental responsibility or decarbonization, something in that with the right words, should actually begin to be regarded as a quality of care. As you may know, the Institute of Medicine, National Academy of Medicine, wrote in 2001 the report Crossing the Quality Chasm, which I helped write. And I authored there the list of 6 aims for improvement that have now been mapped into healthcare. I think not everybody's pursuing them, but they know they should, and that's safety, effectiveness. Safety means you don't harm people in care. Effectiveness means you use science in care. Patient-centeredness, do what matters to people. Timeliness, reduction of delay. Efficiency, reducing waste, and equity, closing racial gaps. I have come to wonder whether something around nurturing the planet or environmental responsibility, or you'd be better than me to know what the word would be, ought to now be regarded as a quality of care, both as a matter of just social responsibility, but also because there are very direct connections, as you said, between the goal of health and well-being on the one hand and the behaviors of the healthcare system. I think structurally, the problems we face in healthcare are not unfamiliar to you, to say the least, in the environmental community. I think they have to do with externalities. The way we've built the healthcare economy, we are quite able to externalize many costs that are borne by the public, but not borne by the healthcare system. And so until we think more holistically about total economy, it's hard to make it all make sense. We have the problem of vested interests in incumbents. Incumbents have learned how to make good money in the status quo processes, and it's uncomfortable to say those processes no longer will work. The key one here is moving care from hospitals to home, especially with COVID now teaching us how valuable and important hospitals are. But that doesn't change the fact that that the hospital should be the place of last resort. We should have ways to help people be healthy outside hospitals, but that's not in the business models yet of hospitals, because that's not how the payment system set up. The other issue, which I'm always hesitant about, but I'm not really sure about this, but I think it has to do with morality. I don't know another way to frame it. I wish I did, and I've been criticized for that framing, but I really do believe there are right things to do, and nurturing the well-being of future generations, nurturing the well-being of people whose names I don't know, but they're humans, is my, it's a duty. And in the American ethos, that claim competes with other claims such as survival of the fittest, or the value of competition, or the value of a win-lose setups. But you can't play win-lose with the environment. There's only lose. And I think the same is true with the health of the public. It's either all of us together or none of us at all in the long run.
Let's talk more about that, because I read your article in JAMA about the moral determinants of health, that there's a moral imperative, that especially that the health sector, who has a healing mission, should adhere to. And healthcare without harm is built on that framework. It's like, okay, health professionals take this Hippocratic oath to first do no harm. Well, how does that match up to their use of fossil fuels and toxic chemicals, and exposing patients to reproductive toxins when they're giving them IV solutions, and feeding patients food that contributes to the very diseases that they're solving for? I mean, there's so many ways in which we've leveraged that moral high ground, saying, we're healthcare, but we're about healing. So can you talk more about what do you think are the moral determinants of health, and how can we institutionalize them so it's not just about enlightened individuals in a health system, but it's the culture, it's the regulations, it's the payment system. It's how do we make that real?
I don't know, Gary, and maybe you've struggled with the same questions, and I'm uncomfortable where my thinking has come, but let me give you the basic logic is, let's assume that we want to be healthy. I want me to be healthy. I'd like you to be healthy. I'd like the world to be healthy. Where will health be found? And the fact of the matter is that health is not generally found in healthcare. Healthcare is, as you quoted me, a repair shop. So you have a heart attack, then you should get proper treatment. If you break your arm, the arm should be set properly. If you're depressed, you should get the right medication and treatment. But all of these burdens of illness, injury, disability, they come from somewhere, and they're coming from elsewhere than healthcare. They're coming from our communities, our lives, where we are born, live, play, work, pray. And we know the causal chains. There are 5. Sir Michael Marmot, who I quote often now, is the great epidemiologist in the UK. And Michael wrote a book called The Health Gap that I strongly recommend be read by everyone. The Health Gap tells us what the social determinants are. There are 5. The conditions of early childhood, what happens to kids when they're really young. The conditions of education, which is whether education is sound and effective and equitable and available to all. The conditions of work, including minimum wage guarantees, but also workplace conditions like you focused on, toxins and things like that. Conditions of elders, how well do we care for the older people among us? And then community infrastructures like transportation and housing and food and recreation, criminal justice. Those five are what social determinants are. And and the science is very, very clear. There's really almost no confusion about these relationships. But there's tremendous variation among nations in the degree to which they invest in early childhood education, housing, and so on. We score low. We are nearly at the bottom for many comparisons among OECD countries for things like the soundness of our transportation or housing systems, food security. We're barely average with education in the world. So we underinvest, whereas healthcare, oh my goodness, and we're at 18% of GDP, headed for 20, with nowhere nothing like the best outcomes in the world. We're 40th, I think, in life expectancy, something like that, or about the same in infant mortality. So it's like we're putting the money in the wrong place. I don't want to stop giving healthcare. I think every organ transplant that would be helpful should be done. Every cardiac surgery that could be helpful should be done. We should give people should have access to the best chemotherapy. I'm not talking about rationing here. I'm just talking about being rational about putting money, if we want health, buying health. And you do that through investments in social infrastructures, education, early childhood, and so on. But we don't. And it's a little, maybe I'm being glib to say it's similar to your environmental interests, but why would we be so short-sighted? What is it about our decision-making processes that have us continue to pour money into the repair shop instead of fixing the roads? In the environmental world, we continue to treat lung disease and not so much pollutants. We continue to treat the consequences of global warming and not so much the warming. I don't know the answer, and that's what's levied the moral. You call it high ground. It can be really lonely on that high ground because everyone feels moral.
You're kidding, man.
I'm no better than anybody else, but we've got to find the energy to work on what's right. And what's right is health, a healthy world. If the economic argument, which is everyone would make more money if we were healthier, of course that's true. I mean, corporations would be better off, economies would be better off, but apparently that doesn't do the trick because it's true, but we don't act on it, not in the long run. So I'm saying we gotta focus on our moral compass. That leads me to things like I'm arguing the United States should join the United Nations Conventions on Human Rights, like the Convention on Rights of Children, Convention on Rights of Migrants and Families, Convention on Rights of Women. We haven't signed those. We should make healthcare a human right in this country. You should be able to get the repair shop when you need it. We should work on climate change as a dramatic assault on the integrity of our current and future generations. We should work on criminal justice. We have a broken criminal justice system here. It's not really justice. It's punishment and not restorative justice. We could have that. Other countries do. And we need to work on those infrastructures like transportation and housing and hunger and get them right. And we need to honor science. We have to go back and understand how important it is that science provide the framework for our actions. All of these things we should have energy for. We seem to be lacking it. And so I guess I beg pardon if I'm using a moral vocabulary. I don't know another vocabulary to use.
So building on that, in the wake of George Floyd's murder and the massive toll that COVID is playing and having on communities of color, a number of states have declared racism a public health emergency in the last year. Building on this moral foundation, what do you think, what role can healthcare systems play in addressing and healing institutional racism in this country? There's many, the health gap that you mentioned has been documented as a death gap in some places where one side of a community is, some white people are living to their 90s and other side of the town, people of color living to 70. And that is replicated in so many different places in America. How can healthcare heal that racism, intergenerational racism?
Yes. Well, first, one is always nervous, two white guys talking about structural racism, which has not afflicted us. not directly. And so we don't have the right authority to really answer the question you're asking. As a scientist, I can comment on the data, but this is more than that. So one of the answers I have is you have to shift the power. The people that have been excluded, people of color, African Americans, especially I'd say Native Americans, they need power, and we've got to. And it's not, it's not for us to give them power. We don't own it in the first place, but we have to be party to that shift in whose voice matters, whose voice counts. So I think one answer to your question is we have to ask instead of tell, and understand what these experiences are and how we can stop being complicit and be truly helpful. That said, the science is clear, and the forms of deficit in health and well-being that people of color, especially now, are faced with, traceable back to slavery. You can absolutely trace this back to origins in this country that ought to embarrass us, be behind us now, if we can get there. But the science is pretty clear. These are forms of withholding of resources, access, voice, and only when we stop that are we going to stand a chance at equity, I think.
So one of the ways that we've been experimenting with other partners like Emerald Cities Collaborative and Healthcare Anchor Network is beginning to see healthcare institutions as anchors in their community, right? Often the largest employers, often the largest buyers of services and goods, often the largest real estate owners, huge political capital to change policy. And so working with healthcare institutions to have them sit down with the community leaders, not seeing the community as sort of just the diseases they're carrying and the deficits and the needs they have, but the assets, the power they have, the solutions that are in their knowledge base and in their power, in their organizing, to sit down and actually solve these things together, to leverage that purchasing power of healthcare to reweave food systems that actually support health, to reweave energy systems that bring renewable energy, not only to the hospitals, but to the community. Sustainable transportation systems, all these things that actually would reduce disease, solve for climate, and leverage this 18% of the economy, not just to treat sick people, but actually to heal the conditions, the housing, the food, the being locked out of jobs, to use their workforce development to bring more people of color into their positions, not at low levels, but at higher levels. I mean, what's your thought about how to, we're sort of seeing the beginnings of that really emerging, but what's your thinking about that?
I think the Anchor Institution Network is a very, very important idea, and I'm glad to see it thriving or beginning to thrive now. And I would urge anyone listening here who's at a corporate level in healthcare to take a look at the Anchor playbook. And the idea, as you say, is to we occupy this big footprint in the economy. Let's use that footprint to help restore the balances, or I guess achieve the balances that we've never had, including overcoming racism, and making sure that the economic impact of our presence helps people who really have been left out. So it's a terrific idea. But there's a problem here, and that has to do with it's sort of so what happens to self-interest in this? For example, for totally understandable reasons, the political heft of healthcare is devoted, I don't know what percent, but I'll bet it's way over 50, probably 80 or 90, to the well-being of health organizations and professionals in healthcare. The AMA argues for more payment to doctors. The hospitals want their rates risen. They don't want controls that reduce hospital payments. They want the money. And that's the game we set up. They're behaving according to the rules, but that's not going to work. It's just not going to work. I think there has to be, to achieve the real idea behind the Anchor Institution, that motivates Anchor Institution, there's going to have to be some change in where the money flows. I've had this crazy idea for a year and a half, and I think it marks me as truly having gone off the deep end. But I would propose to the American Hospital Association, American Medical Association, all of the specialty societies, uh, that I propose a 3-year moratorium on using any lobbying money to get more money. That is, stop asking for more. We're at 18% of the GP of the GNP. Salaries are generally fine, except for people at the low end of the wage scale. So stop and take every nickel we put into lobbying, and let's lobby for no hunger in America, end food insecurity, end housing insecurity. Yes, work on our transportation structure. Yes, work on climate change. Fix criminal justice. You know, if the 18.5 million people who work in healthcare and the 18% of the GDP that's devoted to healthcare started to exercise voice for working on the things that actually make health and wellness and that are truly anti-racist, uh, things would change. That would be a very loud and very highly respected voice. Uh, I don't, I don't think that's going to happen, but I sure wish it would, because we need leadership now for healing, and that means putting money where money isn't going right now.
Amen, brother. We've started to see some of that happening in the work that we're doing around climate and health inequity, where we've created these statewide alliances in Massachusetts and California and Washington, work in Jersey and Wisconsin, and in partnership with Healthcare Without Harm, but also with environmental and climate justice organizations, we've been getting large healthcare institutions to use their political clout to lobby for policies that do raise up environmental justice issues, that do say we don't want to have a cap and trade program that's going to continue to poison poor communities while corporations get to sort of make nice someplace else. So we're starting to see that in a number of places, which is both very encouraging, and it suggests perhaps a level of accountability um, that healthcare hasn't enjoyed. And as you say, they've used most of that political capital to get, higher reimbursement rates. And so, at this point, it's about, why are they doing that? Is they probably are addressing their moral compass.
Yeah.
Is a good thing. And that's critical. And they're also seeing the impacts of the climate crisis through wildfires, through massive floods, through drought, through extreme heat. That's impacting their employees, that's impacting themselves, that's impacting their communities. So I don't know. There's got to be a way of rejiggering the payment structure to incentivize this, so that it's not just out of the goodness of someone's heart or their moral compass, but because we actually think that it's better to prevent disease than to treat it. It's better to have health as a shared value in our society than healthcare as this massive part of the economy. It's a mop-up operation in many ways.
I agree with you. I think that this request for a reallocation of investment is unlikely to win based solely on the moral argument. Although I find the moral argument extremely strong, personally, it may not move the dial. I think the problem here is that it's not enough to ask for stuff. You have to give up stuff, and the willingness to actually say enough is got to be part of the discipline that we exercise. And I don't see that will yet recruited. On the financing side, I mean, this is my field, Medicare and Medicaid. I understand not everything, but a lot about healthcare financing. And I do know the current financing system is unfit for this holistic thinking. I'm not sure I can describe exactly the finance system that is more supportive of holistic thinking, but the one we have now, fee-for-service payment, top-line revenue-driven budgets in business plans in hospitals. No, I mean, that's a formula for just more. It's not a formula for wiser.
Yeah.
I think the more successful efforts may emerge in the healthcare systems that are more globally funded, that actually begin to move funding toward health instead of activity. And in part achieved in part through flexibility. So the same dollar that could be used to help build the next angiography suite could be used to support more food security or mental health supports in the community. We can't move money around that way right now. It's a wrong pockets problem. And even if you're right, and you probably are right, that if we invested in health in the long run, there'd be more money around. It'd be financially smart. The finances, the investor doesn't get the return, I guess is a way to say it. And we need to change that. That's why I'm more a fan of global budgeting systems, either government insurance, national health insurance, where at a policy level, you can think about how much money we have and where the best investment would lie, or in other forms where organizations are supported with global budgets to do the right thing. But we're really far from that right now.
Yeah, there's a good model.
Pardon me?
No, there's a really good model in North Carolina where the Department of Health is taking their $650 million Medicaid waiver and trying to invest in food systems and housing and domestic violence and transportation to actually do that upstream work. If that is successful, that could be an interesting model for other strategies, because it's actually paying for health as opposed to paying for healthcare.
I agree with you, Gary. I'm excited by that. Mandy Cohen, the Health and Human Services Secretary, deserves a lot of applause for courageous thinking. I think one of the challenges in North Carolina, or any place that wants to go that way, is to develop public-private partnerships that work, where the private sector employers, for example, who after all fund a lot of healthcare, see it in their interest to play in that game, and by the way, to capitalize the change. The long run economics could be very favorable, but you do have to invest up front in new forms of information systems and flows of resources. Can they put the coalition needed together in North Carolina? I sure hope so. You and I both see that at Kaiser Permanente, a different kind of situation,
Right.
More a part of the mainstream American healthcare system. But we can see at KP very inventive thinking about climate and environment. You know more about that than I do, but what I've seen is encouraging, and thinking holistically about the redesign of care and the search for wellness. So there may be more than one way to get to this destination. But we have to be unstuck.
Unstuck is right. Speaking of unstuck, I have a question. So you mentioned the crossing the quality chasm, that the report that the National Academy of Medicine did, and To Err is Human was the other one around the same time.
Yeah, To Err is Human came out in the year 2000 and Crossing the Quality Chasm in 2001. So they're 20 years old.
Yeah. And that had a huge catalytic impact, especially that it gave the Institute for Healthcare Improvement a chance to then expand this idea and to recruit hospitals all around the country to invest in some 100,000 Lives campaign and things that would, if you do these things, you will actually improve the quality of healthcare. And it had a big impact. And then it got embedded into some of it into national federal regulations. That's an interesting trajectory. And so you and I now are both involved in another National Academy of Medicine initiative, a grand challenge on climate and health. And part of that is decarbonizing the healthcare system, which is something that Healthcare at Home is deeply engaged in, with roadmaps and measurement tools and Race to Zero initiatives with UNFCCC. All that's happening. There's a big cohort of hospitals. But the other parts of that are interesting. It's looking at, in which you're in the center of this thing, looking at, what are the financing mechanisms that could actually incentivize healthcare to be great, to be more climate smart, to be investing in their community. What are the perverse incentives we'd want to get rid of here, or perverse regulations that impede that? So sort of a policy dimension and a financing dimension to this. What do you think is possible, taking the playbook that you did around quality and mapping that onto this climate moment now for this initiative. What's the highest aspiration you think we should be holding with this grand challenge on climate and health?
Well, I learned a lot in that era of trying to pull together national, international movement on quality. One is that bold goals help, not hurt. We are so timid, and there's this theory that you just need to be incremental. No. So many people are, as I believe you and I are excited by something, by trying to achieve something really big. And so I would say let's be bold and not just think marginally about where we're going to get to. Eleanor Roosevelt, I think, said you must do the thing you think cannot be done. So I think we should be bold. I think the roadmap, by the way, that Healthcare Without Harm is now published is spectacular and very, very edgy, because you've just shown how big an achievement it could be. I think the other thing is it's to work both with intrinsic and extrinsic motivation. I may be wrong about this, Gary, but I think in both of our fields, quality of care and climate, the workforce wants to do this. I think the average person going to work in healthcare or in any of the sectors you try to influence, they really want to help. They love to be part of something bigger than themselves. And somehow we've erected corporate and financial structures that impede, that chill or block intrinsic motivation. And I think we should maximize that. I think putting out a bold goal and getting people on board helps a lot. At the corporate level, when you have boards of trustees and finance officers and responsible executives, that's not quite enough usually. You need to line up the other influences, and the alignment is everything. And you're right, finance is part of it. And I told you, we have a toxic payment system right now that does not support holistic thinking about health, and surely doesn't support investment in, is perceived not to support investment in decarbonization or environmental responsibility. So we have to change payment to better signal that this stuff is among the products wanted. Just like we need to internalize the cost of carbon, we need to internalize the externalities with which healthcare impairs the planet. I don't know another way to do that. Healthcare has the other history, though, of accreditation processes, independent of tariffs and payment levels. You need accreditation by the Joint Commission, for example, in order to be a healthcare provider. Well, if we begin to map holistic care and environmental responsibility into what it means to be an allowable provider, of course, the providers at first will resent it. They don't want it. They've got enough requirements, they'll say. But on the other hand, that changes the game. Yep. So I think it's an alignment issue. Money, accreditation processes, and licensure. I think it's also celebration. I don't want to sound hokey about this, but actually recognizing and thanking the places that actually do go out ahead on this.
Yeah, well,
signals lined up.
Yeah, alignment is right. The good news is that a lot of the renewable energy technologies are a lot cheaper than fossil fuels at this point, and it locks in prices that don't fluctuate, and it addresses those externalities. So there's a number of places where investing in climate smart healthcare is actually a strong, straight up business proposition, even before you address the sort of health and social externalities. But there needs to be a much broader business case, and this may be something that NAM could do, that addresses all of these things together, so that alignment is a lot stronger.
You're interviewing me, not the other way around, but I do have a question for you that this builds on. I've had the enormous good fortune to get to know and work with Amory Lovins for many, many years. And among his among the things he's taught me, largely through his book, Natural Capital, has to do in the energy regime with how you could price savings. Like you can decouple energy payments from production of energy. For example, as he puts it, a kilowatt or a megawatt saved is just as valuable as a megawatt produced if you can develop a market for it. And a negawatt has value. So does an empty bed. So does a visit not had. So does a medicine not taken. And
Yeah.
I think maybe if we could start to have healthcare learn a bit from the environment, from the energy regime, about how you can begin to put the value on the real benefit instead of just on the production system, it might be a lesson worth learning. So I know I've thought about that a lot. My wife Ann, as you know, is in this field, and we've talked about could you have the equivalent of negawatts in healthcare in which hospitals begin to celebrate empty beds?
Well, one of the areas of this global roadmap we've developed is what we call uncharted territory, right? So as we do things upstream, it means that we may not need to do more care. So if we feed people who are hungry, if we create healthier food systems that don't contribute to obesity and diabetes and heart disease, then we won't be filling as many beds. And can we consider that part of our climate mitigation footprint reduction? Because it's sort of it's addressing what you're describing. It's the same as, doing telemedicine. People don't have to come to our facilities. Maybe we can talk them through and do whatever diagnosis we can on the phone. Hospitals that said, well, we may take us 5 years to sort of move into this telemedicine thing. They did it in 3 weeks in NYU Langone. So, there's the boldness and the speed. And there is these upstream interventions that could have incredible benefits if health is the goal, if equity is the goal, if sustainability is the goal, if morality is the goal.
Yeah, the big and most exciting part of that to me, beyond the goal, is to reimagine the production system. That is, we can't start with a clean slate, not when we occupy 18% of the GDP and employ a fifth of the workforce, but we could imagine. And if you could imagine starting again, and let's just take 15% of GDP, we don't need 18, but build it for health, build it for thriving, build it for equity, build it for joy, so that each individual gets all the care they want and need exactly when and how they want to need it. But the goal is health. What would that look like? It would not be the system we have. And then I imagine if we could imagine that the health production system of the nation, and then see if there's any pathway we could imagine that would move from the one we have to the one we want. I think it'd be quite different. The other thing is, I don't think there is a debate in my field about whether we could still meet all the what I call the repair shop needs. Could we still do every organ transplant? Could we still do that works? Could we still do every rescue therapy in ICUs? I say yes because I can see the amount of money we're wasting on stuff that just doesn't do anything at all. It's nothing but paperwork or pricing games or drop balls or patient injuries. And so I think there's a lot of money in that. The equivalent in the energy world is stop using energy which nobody is using. Back to my friend Amory Levins, who whenever he walked into a room would point to the corner that's being lit up. He said, why are we lighting up the corner? Nobody's using the corner. And I think we have the same problem in healthcare.
Let me ask you a question about leadership, because we're talking about a kind of new kind of leadership that's required at this moment of time.
Yeah.
It's intersectional. It's understanding the interconnectedness of everyone and everything. And we've been at Healthcare, we've been trying to think about what are the sort of qualities of leadership that is required. And we talked about that it needs to begin with humanity. So it needs to tap into people's personal purpose, and it needs to be about listening. You talked about listening to what the community needs, or listening what people of color need. Deep listening and humility as an important quality. Equity, actually trying to address the generations of racism which have impacted everyone, and taking personal responsibility. One of the struggles we've had is, well, that environmental stuff, that's not my job. That the food system, that's not my job. Housing, that's not my job. I take care of people that come into my hospital. So it's taking more responsibility. I don't know. What do you think about those values, or what would you add? What would you say are the kind of leadership qualities that are needed at this moment in our history and the moment on the planet?
So much. I mean, honesty for sure. I think it's the humility you're talking about, which is, I think the best leader in anything, but certainly now, leads by invitation, leads by saying, what would you like to bring to this? And understands how many gifts people have to bring instead of having to have all the answers. Um, Valuing experimentation and trying things. I think the best leaders say, if you think it's smart, try it. I mean, you don't have to check the manual. You got a brain, and I think this release of energy, of human energy, human spirit, is very, very important to the kind of leadership we need today, especially with respect to energy and environment, because many of the changes have to be local as well as central, and you need that local intelligence at work all the time, that local will. I guess a story. The reason I'm hesitating is a story. I did an interview this morning with Michael Dowling, who's the CEO of Northwell. We were talking about burnout in the healthcare world, burnout of people in the COVID pandemic, and how to mitigate it, how to heal. And I asked him about his experience, and he said he just can't get over the amount of spirit he finds in his workforce. He told me the story of, he makes rounds like all CEOs should. He goes out to the ICU and he was in the ICU sometime this year visiting, and a nurse came out of a patient's room, and she seemed upset. And so Michael Dowling went up to her and said, is something wrong? And she said, yeah, it's been a bad day. My mother's in that room and she just died of COVID. And he said, obviously sympathized and said, you need to take all the time you want to go take care of yourself. She said, no, I want to be at work. She doesn't need me anymore. Wow. And I'll tell you, Gary, that's everywhere in the workforce. And so a leader's got to know that and stop thinking that they're smarter than the workforce or more noble. They're not. And I think what is important is saving the planet, or having the health and healthcare we want. Can we release that energy instead of sitting on top of it?
So my last question, Don, this has been such a pleasure chatting with you. My last question is, what gives you hope? You've been on the case for a long time, longer than me. What gives you hope? What fuels you?
The most immediate answer is the youth I meet. I have 8 grandchildren. I have students at Harvard Medical School. I'm lucky enough to have young people as part of my life. I get calls from people who want to make career choices. Boy, I'll tell you, if we could turn this over to the young, we'd be done. I think there is something generational going on here, where people are finally saying, enough of this, enough of this. Some is anger, because if you're Black and young today, you're tired of being put at that disadvantage, and you're gonna do something about it. I think the same is true about environmental responsibility. I don't know if you saw this amazing conversation between the Dalai Lama and Greta Thunberg that the Mind and Body, I think it's the Mind Body Institute, had last month, and you could just see nothing's going to stop her, nothing. And I would bank on that. I think that the setup right now is for change, in the sense that the coalition of people who are being placed at disadvantage by the current political structures that so seriously support the incumbents and the inequity. The coalition of people who put place at disadvantage for that is enormous. It's way, way more than 50% of the public. And so some leader may emerge who will say, you and you and you and you're really all together. And that emerging possibility of solidarity, I continue to count on and hope for.
I'm with you on that completely. That moves me as well. And there's been some incredibly encouraging developments over the last several months that have proved that out, and will continue to do so. So I just want to thank you so much for joining with me today, and I'm very proud to have you as a colleague, as an ally in this broader healing mission that we have both taken on in the healthcare sector and in society at large. So I look forward to all the amazing things we could continue to do together in this National Academy of Medicine, and whatever level of partnership we can make happen. Thanks so much.
Colleague, ally, and friend, Gary, and I'll be with you all the way.
Great. Well, thanks everyone for joining. If you have questions, please send them to us in the chat and we'll try to answer them subsequently. But thanks for joining this time, and we're going to be having a series of other conversations that people we care about and want to hear from during the course of the year. So we invite you to join that as well. Thanks very much, everybody, and have a good day and stay safe.
Thank you, Gary.
All right. See you, Don.